So I want to introduce Steve Hanau, who's a very experienced and skilled and nationally and internationally known vascular surgeon. He's currently at Presbyterian Hospital in Albuquerque, New Mexico. Steve has been on a lot of the really important trials from LymphFlow to Destiny 2 to Imperial, etc. And he's going to show us a great case today, I'm sure. Hi, Steve. Tell us where you are and how things are going and what's happening today.
Good morning, Srini. Good morning, New York City. Welcome to Albuquerque, New Mexico. Here at Presbyterian Hospital. Behind me, I've got Mario and Ed, and with me, Ricardo. We've got Scott, Sonia. I think James is back there, Ed. And we got a great case for you today. 61-year-old man, very pleasant guy. Unfortunately, not a very good compliant patient. His recent A1C, as you can see, has been above 14 with chronic renal insufficiency as well. And so he came to us with a non-healing second digit that he's been struggling with for about the past 3 months or so. An arterial duplex demonstrated monophasic anterior tibial outflow, but an occluded tibio-perineal trunk, perineal, and posterior tibial artery. So our task today is to see if we can get that foot to kind of perk back up so we can get this wound healed. So going to our angiogram here, which we did just a few seconds ago, we start with an anterior or an antegrade approach. Stiff wire and the usual. You can see our beginning angiogram here. SFA, P1, P2, P3 look good. And from the outset, the top of the tibials seem to look pretty reasonable. And as you can see, as we kind of zoom down, our anterior tibia looks reasonable, looks like the dominant flow vessel, some minimal disease, but our posterior tibial and perineal artery diffusely diseased. But it looks like an imminently crossable lesion. So these are kind of infamous because they look like chip shots on the outset, which actually is one of the reasons I thought this might be a good case to talk about and do in 20 or 30 minutes. Yeah. And so in setting up for things, we're looking at outflow. His ability to stay still is a little bit limited, but his dorsalis pedis kind of terminates before it even reaches anything in the forefoot. And his plantar vasculature is very poorly reconstituting. But you can still see that the PT is something that we can probably get to. So my usual approach with this is to try to get this down into some kind of an antegrade position. And I've been hearing your talks this morning, and so my usual wire escalation is to start with a 014 Mongo wire, and I shape it and try to steer into that. And in attempting to do so, do that with a road map. I think that really helps, and if you have that technology, by all means, use that. And so as we get down into the segment where I feel we can cross, you can see that it becomes much more hostile, and my wire simply was not behaving at all. I think you guys talked about C-top earlier this morning, so you can see the way that everything kind of falls to the side, and so it kept shoving me, as we predict with C-top, into a subintimal plane. And so in an attempt to try to steer back in from the top, I switched from my Mongo wire to a halberd wire and shaped it in such a way that I would try to kind of get back into the fibrous cap. And unfortunately, that was something that just simply was not going to behave very well for me. So I ended up coming in from the bottom. So when I go retro, I strongly prefer ultrasound guidance. And for those of you that want a long career and avoid radiation, I strongly recommend getting expertise in ultrasound guided versus radiologically guided. I like to use an 018 platform for the extra robustness in the wire as well. And I don't typically put a sheath in. So what I do is I'll put the 018 wire and then behind it an 018 support catheter. And so in essence, what I'm doing here is I'm meeting up to where I couldn't get to before. So as we've probably heard this morning, it's much easier to penetrate a fibrous cap from a retrograde orientation than from an antegrade orientation. And I think that little move here demonstrates that nicely. And then effectively what I'm doing here is kind of a rendezvous where I'm externalizing the wire from my antegrade femoral sheath out through the foot, which I'll show you here in a second. And so basically that's the setup. I'm going to downsize to an 014 wire platform suitable for a number of things, including atherectomy. But before I do anything else, and I think there's some people on the panel that are as passionate as I am about intravascular ultrasound and peripheral vascular disease, I don't ever do a case like this unless I've done IVUS. And so that's kind of where we're at. So by all means, please fire away with any comments or questions that you might have at this point.
Yeah, so great demonstration. I think I noticed you got antegrade proximal SFA access there, right? You were done at the lesser.
That's correct. Mm-hmm.
Yeah, so just to let everybody know, it's a relatively safe access that you can use. We're actually we submitted a paper for publication to show that even in patients who are anticoagulated, the complication rate is really no different than those who are not on it, and hopefully that'll be coming out soon. I think the other thing to notice is if you notice, really looking at the cap morphology is very important. I think you showed a great demonstration of you tried from above, used various guide wires, and then basically got retrograde or pedal access right away. We talked about, do you put in a sheath, don't you? Many operators put in small sheaths, either a Cook or Merit sheath. I think the Cook sheath's like 2.9 French. And then other people don't put in a sheath. If they're using it just for crossing, then they cross and then they fix from above. So we got a great panel today. We got George Chrysanth, we got Peter Ferrugia, we got Dr. Finelli, Brian Fisher, and Sahil Parikh. So any comments from the panel in terms of, looks like we've crossed. What would be your next step here? I think most would agree IVUS, and then what about after that?
Yeah, I think, that's just it. It depends what the IVUS shows. I think Dr. Finelli has shown that the calcification is going to be a predictor of outcome depending upon what technology we use. So I think that once we see the IVUS, you'll get not only the constituency, the plaque and the plaque morphology, you'll get sizing. And those are the two important parameters I think that's going to dictate what we do next.
Yeah, I think everybody's in agreement here, Steve, in terms of what does the IVUS show in terms of the plaque composition and degree of calcification and so forth.
All right, so we're looking at our IVUS, and let me know if you can see that on the panel.
Yes.
Yep, we can see it.
Okay. And then hopefully we can get some element of fluoro so you know where I'm going. So as we look at IVUS, one of the things that immediately should leap out is the plaque morphology. So we've got circumferential calcium. So that's one thing. I'm also looking at vessel diameter on this, so it's about a 2, maybe 2.5 as I'm pulling back. And probably the most important thing if you're thinking about plaque modification is to guarantee that you're within the true lumen. And so far, so good.
And early operators always ask, what if I'm predominantly intraluminal, but I had a short segment of subintimal crossing, especially in tibial vessels, and in the use of atherectomy in terms of orbital atherectomy and so forth. I know Jihad, Mustafa, and Fadi have shown that typically, if you have just short segments of subintimal crossing, orbital atherectomy is pretty safe. It just ends up creating a bigger channel through that area. Obviously, the risk is that the device can get stuck. So you have to be very careful in terms of wrapping. How does the panel feel about, because, oftentimes we think we're intraluminal completely, and there may be small, short segments of subintimal crossing. Does that change your choice of vessel prep or atherectomy? Peter?
So, from my perspective, especially looking at this, I don't know how you wouldn't put in a diamond bag. For a short segment subintimal location, it doesn't change anything for me. But if it's a long subintimal crossing, then I think it changes which device. If we're going to use atherectomy, I think you almost have to go laser at that point.
Does everybody pretty much agree? Yeah. So it looks like it's you've got really diffuse circumferential calcification in this tibial vessel. What's your plan, Steve?
Yeah, so I agree with the Diamondback. So I'm taking a 1.25 micro, and I'm using a little bit of faith on that IVUS because truth be told, I wasn't even able to get the IVUS 100% all the way down into the ankle as I had intended.
Given the size of the
thing
vessel,
I want to point out to you is
What's the size of the vessel? We have a question, Stephen.
about 2.
so wouldn't you consider using a solid here? I mean, we're not going down into the pedal vasculature, and at 2 to 2.5, which is what you were showing on that IVUS, probably better service with the solid.
Yeah, I think that may be the punchline. I wouldn't necessarily sell myself short as I'm done. Once I get through this AT, we've got some more potential stuff. So if I can avoid opening up multiple devices and use the full capacity, right? So we start at 60, go to 90, and ultimately 140 RPMs. And so that's the beauty of orbital atherectomy, is that you can kind of dial it up, and then we'll post-dilate. But I still feel like I'm going to end up having to do some work down into the pedal. So a 1.25 micro gives me one device that I can take care of the entire leg with. Anybody disagree with that?
No, I think that's a good plan, Steve.
Yeah, so we're obviously, Steve's using the CSI Diamondback. It's an orbital atherectomy device. And, you know, when it may be inflow, but it looks like there's probably some SAD or small artery disease below the ankle, like Art Lee had talked about. Maybe, Steve, while you're doing this, we're going to get to our first couple of talks real quick, and we'll come back to you if that's okay.
Beautiful.
Okay. Tell us where you're at this point.
So we just finished our 3-minute inflations along the length of the AT, and we were just about to take a follow-up angiogram here to see what we've got. So judging by that, I suspect that, oh, that was nitro. Okay. That was a terrifying moment for me for live TV.
There's a good saline injection.
That was, it was nitro, actually.
Oh, nitro?
Like,
okay. Well, now hopefully it'll look even prettier.
So we still got some work to do here.
Yeah.
Which, as I alluded to on my choice of 1.25 micro, is that I've got to get down into the pedal and do some work there. So that's my next step.
So maybe we can ask, we've got Dr. Finelli on our panel, who's obviously very well versed in blood vessels and calcification. Dr. Finelli, you know, in Europe currently, I know you're good friends with Marco Manzi and his team as well. What is your vessel prep for tibial vessels at this point?
Oh, generally, I mean, atherectomy should be the good option when there is so much amount of calcium, because we saw on the IVUS, this is definitely a circumferential distribution, 360 degrees. So there is no way using any other device to debulk the lesion. And at that point, obviously, you have to perform a better angioplasty B. You can use a larger balloon and keep inflated for a longer period, and see also the outflow distally if it is enough to keep the vessel patent.
So are you doing sculpting balloons? Are you doing just standard angioplasty for your vessel prep? What's your algorithm?
Generally, after atherectomy, we use a standard balloon, or we use a low trauma balloon catheter.
What type of atherectomy are you using?
We have not so many. I mean, dedicated, we use the Jetstream sometimes. CSI is another option. So they are, depends.
So, Brian, you know, as a vascular surgeon looking at this case, I assume you would have approached this from an endovascular first approach.
Micropuncture access.
Absolutely. So that, you know, it's a great point.
Micropuncture.
You look at the difficulty in what he's having to do going distally. You know, I've sewn in the vessels down in the foot and at the ankle, and when the target is terrible, you know, you're in a bad spot. And actually, the endovascular route can be a better option. Because again, you aren't actually fixing the lesion. Then you've got incisions that are there. It doesn't stay open very long. You've got those incisions that end up not healing as well. So this is a great choice. I agree with Steve wholeheartedly that I would attack this from an endovascular standpoint first.
Yeah, yeah. So maybe for the so Steve, what's your plan right now? Just kind of talk us through what your thought process is, if you don't mind.
Let me have you. I'm going to invite you to take a peek down into the foot.
Yep, we see it.
I lost my monitor here, but okay. So basically, what I want to do is I want to maintain that retrograde access, but I want to redirect my wire down into the pedal architecture. So I'm taking my micropuncture access just to kind of save my position. I don't usually use sheaths, so that's probably the downside, but you can still save your position here. So I'm using this little device there. And then from the top, I'm removing my wire there. So that was my Viper wire. And I'm going to go in with another wire depending on what I see here on this angio. Now that I've got a catheter right down into the common plantar distal posterior tibial.
So basically, you're trying to get a better sense of your below ankle vasculature at this point, right?
Yeah. So it's actually not bad.
Pretty good. Yeah, it's not bad.
But you can see it's stagnant. So I'm going to hit that with a little bit of nitro here and then take another shot.
Sometimes it could be also useful in this situation to remove the pedal access, because if the patient is very sensitive, you stimulate, the spasm. And at this point is no more need to have a double access because you already reconnect the vessel.
Were you able to hear that, Steve?
Yeah, I'm just too superstitious.
Right.
Yeah, so I've got a nice looking track here on my road map. I've got a Xi'an black here. I'm trying to kind of squirrel through here. It's been a little shy for me this morning.
So I think in general, we don't want to take pedal loop interventions lightly for those watching. We have a lot of fellows that attended this course, about 80 apparently. And so, obviously, pedal loop interventions are very complex. We have a lot of new data and technologies now. We still don't have any good randomized control trials, but realize that the patency rate is around 50% if you look at all the data. That's at about 6 months. But the failure rate is about 60%. If you look at a technical failure rate in terms of being able to cross and deal with it. And remember the consequences of really messing up the pedal loop. It's your final outflow of the foot, of the limb. So you want to be very careful when you're doing these interventions, and obviously reserve them for really CLI patients in advanced limb salvage. It's interesting that you brought up the microstent, Dr. Finelli. I mean, I can't really talk about it. I'm on the DSMB committee for them. But yeah, it's interesting technology that we'll have to see.
I wanted to ask about that. So I do a lot of off-label coronary stenting in the proximal tibials, especially, and it's it's very effective, and the data's not bad for it. I'm wondering with that, the microstent looks like it has a lot of promise. Does it preserve those collaterals? So let's say, like in the proximal anterior tibial, that clavicle comes off laterally and goes up to the geniculate. Whenever you put a stent there, a coronary stent, it almost always preserves that collateral, even when it goes down. When the stent goes down, or the vessel goes down distal to that. Does the microstent, because of its characteristics, does it actually preserve those collaterals, or does it kind of close those off?
Yeah, definitely yes. It's similar to the coronary stent. It's a burr stent. Also, it is a woven structure. There is no possibility, to block the flow within the collaterals. So at the moment, for the few cases we had a pretty nice result.
Okay. And is there a plan for a drug? That would
we have to ask for the company.
Okay. All right. that would make me really excited.
So Sahil, you're a busy operator at Columbia. How often in your practice are you or your colleagues really intervening on the below ankle vasculature at this point?
Yeah, I think it depends on the substrate. We frequently will have, probably in about 5 to 10% of these patients. The challenge is that we try very hard to preserve options. And frequently these people come with Wi-Fi classes that are, as we've included in these trials, relatively low. When they have more than that, it's usually a hybrid approach where we'll try to revascularize the loop, and then we'll have one of our surgical partners do the transmet or whatever reconstruction that they need. So in those situations, that's when we're the most aggressive. And we, if we did it ideally, what I've heard around the world is that they sometimes will leave the wire in and take them straight to the OR, so they don't take out the pedal loop in the operating room. But that's not practical in our environment.
Yeah.
And so usually we'll do the intervention. But it's for these kinds of complex CLI patients, it's probably 5%.
Ryan, how about
and
your
it's
practice?
increasing, unfortunately.
That's a really important point. Yeah, so we have a pretty busy practice, both hospitals, kind of mix of hospital and OBL, and maybe 10 to 15%. And again, of course, it's depending on the patient type. But it's an important point because, you see guys like Fadi and Jihad and Art Lee, they do pedal arch reconstructions and it looks sexy and it looks amazing and it starts to kind of look easy.
Yeah, Farisi, Dr. Finelli.
Yeah, Finelli.
Make it look easy, right?
Right, they make it look easy. However, there's so many things that can go wrong in that area. I don't, this is not an area for the novice interventionalist. And there are cases, and we're seeing in some groups where they're going and interrogating the pedal arch every single case. I would strongly discourage, that type of behavior.
I think this is a very challenging area. What is important, in my opinion, and what we do in our practice is the evaluation with the clinicians, evaluating the foot in the foot clinic, because they give us also some information what to do and how much aggressive we must be, because sometimes there is no other option, so we have to try everything. But in other condition, maybe you work for an hour and immediately after everything is closed again, or you have a more severe condition. So you have to, it's difficult to find the good balance, but definitely I think you need a little bit more experience if you work here comparing to above the knee.
George. Yeah, and I think the other thing is the emergence of some of these newer devices and technologies that might help us know when we've achieved our goal too. Yeah. Because I don't think there's any harm in waiting and staging. But also, if you reconstruct tibials and then you've got a device that tells you more or less that your tissue content of oxygen is good, you've got favorable conditions for wound healing, then you can stop and not even put yourself in a position to make things worse, because we've all hit on it, but I can't stress enough how easy it is to mess this up.
Yep.
Very easy to mess this up, and you have no bailout at that point.
I completely agree, and to echo everyone else's words here today, I think that you tend to get more aggressive if you know that they're going to be going to the operating room for an amputation, to try and at least get them healing to a transmet as opposed to a whole foot. But again, everyone said it very well. You can really do a lot of damage here. So it's not something that should be taken lightly.
Yeah, and I think the way to think about it is that, you've got two options when patients that don't have the final major outflow below the ankle, right? You got pedal loop interventions and you got DVA.
So we got our posterior tibial to behave, and as you saw, whenever I can visualize the pedal loop, as to your excellent points on the panel about the ability to screw things up, I felt like we did what we needed to do, which was to get down the posterior tibial artery and then down to the common plantar, and I could see the split. As you recall from our scout images, our perineal was completely occluded. So I've just gone through with the 1.25 micro, and I'm going to take the device out and do an angioplasty there. And, I'm not touting that we should always kind of go for broke and get 3-vessel runoff, but I'm going for broke to get 3-vessel runoff.
Yeah, no, it makes sense. And I think that's where we're still learning a lot, right? CLI endpoints, when do we stop? How much do we do? I think you see it even in deep venous arterialization. How much of that plantar venous arch do you reconstruct? How much flow do you have to get? They always talk about reflux into that, Lejar's venous plexus, right? Because you got to fill the sub-Q and the dermal veins and so forth. So, yeah, point well taken. What do you guys, maybe the panelists can tell us what is your endpoint, so to speak, when you're not using devices like FlowMet or pedal arterial acceleration, which we're going to be talking about later today. How do you guys decide when to stop?
So I think a big part of it has to be, what have you achieved? Do you get to a safety point? And then looking at, especially in this patient who's a chronic renal patient, how much dye have they had? How long have you been in the lab for, to determine whether or not to proceed and try to open up another artery or to stop where you are?
May I ask a question? Is anyone using, perfusion imaging? for you guys?
Yeah, we are, and I've used it. I don't use it as regularly as I probably should. It looks great, but I have trouble sometimes doing the interpretation of what I'm seeing. It can vary somewhat depending on the case and from patient to patient. So I haven't figured out the key in finding, again, kind of a consistent result, and then what do I do with it based on what I found.
Can you tell us what you're using, Brian? What machine, what software? Are you talking about the Siemens perfusion imaging or Philips, or are you talking about something else?
Philips. Yeah, we have the Philips, their newest system. We have that all integrated into two of our hybrid suites.
How about you, Dr. Finelli? Are you using?
Yeah, we use the Philips system, but because I think this could be useful, we are still trying to understand the value.
Yes.
It could be useful to understand when to stop, because the problem in these patients is not only what to do, but also if you achieve a nice results, it can be sufficient, to healing the ulcer.
Yeah, I mean, I think the perfusion imaging is correlated a little bit better for those of us that do stroke interventions in terms of the brain, but in terms of limbs, we don't have a good idea of, what does it tell us and what it means. I think that's the hard part.
The big issue too is you just see, and we see this in even doing a bypass. You do a FIM perineal bypass, and you check signals right as soon as you're done. As soon as you've done the anastomosis and the signals, they're not great. You go and you check on them the next day, and they've got a palpable DP in posterior tibial. Not a bounding, but then you can actually palpate it. So I think it takes some time for those vessels to dilate up, and that's one of the challenges with the perfusion, doing perfusion studies in the operating room. Sometimes that interpretation, again, it takes time for those vessels to plump up. We really have started to utilize PAT, as we're going to discuss later.
PAT or PAT, yeah.
Yeah, I mean, it really works. It works well and has given us a good guideline. I'm big on, I'll stage a lot of this stuff. So if it's going to be over 2 hours or something like that, then I'll stage it, bring them back, and then we can evaluate them in between and see if we even need to do anything else. Sometimes I'm surprised and we get those vessels plump up and we end up, we're done, and we've done the job a little bit earlier than what we thought.
Sahil?
Well, I think Steve's demonstration with the DVA was proof positive of that approach. The TCPO2 continued to rise over several months, and it was a relatively long ramp up. Yep. And I think that, with that torrential amount of flow, even with that much flow in these small vessel disease patients, it takes time. And so I think, perfect is the enemy of good enough. And I think if we stick to that adage, we'd probably be better off. Errors of omission are sometimes okay in this population.
Yeah, and the ALPS registry bore that out. At about 8 weeks or so, the TCPO2 rises to a significant level if you have a successful DVA. And obviously now there are also people are looking at flow rates with ultrasound, kind of like you look in a dialysis fistula. What's the flow rate as soon as I'm done? They look at proximal third, middle third, distal third of the outflow vein, which is the conduit, right, in this case, to really see, is it progressing the way I want, or is it starting to deteriorate, requiring reintervention? So, I mean, we have a lot to learn in terms of CLI endpoints for sure. Hi, Steve. How's it going?
So we're just finishing up our angioplasty of the perineal here, and we're going to take a picture here.
Okay.
I brought out our CO2 Commander Elite so we could demonstrate to the point on the panel, this gentleman's got renal insufficiency, and at what point do you decide to stop based off of that? Well, if you don't have CO2 in your lab, then you're probably limiting your abilities to take care of these CLI patients. Yeah. So when it gets to the point where, we want to take some extra pictures and get some details, obviously IVUS is going to be something that we use a lot, and we've demonstrated our use there. But CO2 is absolutely something that if you don't have it in your lab, you're not a CLI center.
Yeah, I think so.
Especially with the shortage we faced back in the spring, right?
Yep.
Absolutely.
So Steve, do you have any tricks for people? I mean, my experience has been that CO2 is great for big vessels. Once we get down in the tibials, unless you have a catheter down, it's hard to get really good pictures. So you want to share some of your tips and tricks for those tibial images with CO2?
Yeah, I think the biggest misconception is that, you want to try to power it out through like you do with contrast, and CO2 can be painful. So, you just have to remind yourself that all we're doing is we're displacing this column of blood And it just takes a gentle touch here. So you can see what we're aiming at here is just to get a sense of where we're at. Posterior tibial and anterior tibial are finally kind of on pace, on par with each other. The perineal is coming along too. We've been using quite a bit of intraarterial nitroglycerin. I usually tend to do 400 to 800 doses of that. So
one thing we've seen, Sahil, is that, typically we'll have a sheath in the P3 segment of the pop that helps. If you're working with 014, 018 wires, we'll put in maybe a 5 French Navi cross catheter down, use a 2E bore so you can get good CO2 injections below the knee that way. And obviously a lot of these machines now have CO2 settings, which kind of helps us.
So we're still getting quite a bit of high resistance out of that foot, but it's going. And I know you all talked about Dr. Coombs' data regarding, the time component after DVA, and I think it is, as you alluded to, applicable to these cases.
Yeah.
So I think I'm at the point now where I may be pretty happy with what I'm going to get, and
and we've seen that too, Steve,
we'll
in our
just
CL.
let him sit.
Yeah, we've seen that in our CLI population. I've had quite a few podiatrists over the years would call me at about the 2-week mark and say, "This wound is not healing. It's not getting better. I'm worried. And we'll do the angiogram, and all the small vessels have really plumped up at about that 1 to 2 week mark, and you'll be amazed how much your perfusion has significantly improved, and you just have to wait and give it time. We had a question about the sheath, is it occlusive? But typically, the sheath we're putting in, we're making sure that we're putting it in a normal segment of that popliteal artery. So if the P3 segment is diseased or narrowed, I wouldn't put it in there.
So you can see, the question about clarity, I'm looking at, medial and lateral plantars and tarsals, and you can get a sense that it looks good. And the temptation is always going to be, let me get a balloon down there and get a beautiful angiogram. And you just have to avoid cosmetic angiology. It's the worst thing. It can create a dissection. All this work that we did, you can ruin in a single inflation. So looking at this, I'm kind of thinking that we might be at the terminus. Any thoughts?
No. Thoughts, panel, on endpoint here?
Agree.
No, I agree. I agree completely. The other thing to keep in mind is that the patient didn't get like this overnight, so they don't have to get fixed overnight. You can be patient and just kind of see how things go.
Yeah.
And I think a nice, Doppler or duplex ultrasound of the, the DP, PT, et cetera. There's your endpoint. You guys, as surgeons, you guys do this all the time, just like a lot of busy CLI operators do. And so you can look and see if your signal is significantly better. Maybe it's biphasic at this point instead of monophasic or instead of absent. So a lot of options. Thanks, Steve. I want to thank you and your team. Great case. Very diligent and disciplined as you always are. And, we looking forward to seeing you again.
Thank you, Srini. Take care.